Hi, my name is Ruth Beecher, and I'm a historian here at Birkbeck at the University of London. And I'm the principal investigator on a project called Recovery Histories, which is funded by the Wellcome. The project really came about from a previous project that I was working on. Um, that was the Sexual Harms and Medical Encounters project, where I looked at why practitioners really don't recognize, identify, and respond to child sexual abuse in the family. And this project really brought me into contact with a lot of survivors, practitioners in social work, in medicine, in psychiatry, and also, I guess, academics who are working in similar fields to myself, because I'm a historian of children and families. And so myself and a colleague from the University of York, Dr. Victoria Hoyle, who's on our advisory group now for this project, got together and we set up a network about child sexual abuse. There's lots of research that looks at child sexual abuse from a kind of biomedical perspective or a psychiatric perspective, but there's very little historical research being done on that. So we thought that was really important to remember the histories of child sexual abuse. And we got the network together. We did 2 meetings. One was in York and the other was in London. And at those meetings, people looked at the kind of priorities that we should have in the future for researching the histories of child sexual abuse and why they mattered. And one of the things that came up was why, whenever people talk about recovering from child sexual abuse or living with the aftermath of that, they talk now most often in the language of trauma and the language of recovering from a psychological harm rather than any other sort of harm. And so I became really interested in that and thought that that was a really interesting concept to develop and to think about in terms of the histories, also because the NHS spends millions of pounds on people who are experiencing distress because of childhood sexual abuse. And therefore, if we could think about other social supports and other ways that people recover, which is beyond therapy, let's say, or beyond medication, then I think it would be really great for individuals and for practitioners who can send people to places where there isn't a waiting list, and also just to understand those histories and celebrate them. Yes, so I'm the principal investigator, which basically means I wrote the bid to the Wellcome and explained why I thought the project was really important. And then I have a team around me of researchers, and they're a fantastic team, really creative, really exciting, very motivated. So I think you'll be meeting those later on. But just to summarize, I've got working with me Adeline Moussillon, who's a French anthropologist who really works with people very close up and over long periods of time doing ethnographies and participant observations. And I'm sure that she or Baljeet will be saying more about that because I don't know anything about it. And then I'm working with a colleague called Katie Elliott, who's really, I guess, apprenticing in history. She's a very experienced researcher in sociology, but this is her first foray into oral histories and into archival research. And the other person on the project is Baljeet Kaur, who is an ethnographer and has done a lot of really creative cultural work in the East End of London. So I'm sure they'll all be saying more about themselves, but that's just a very brief introduction to them. Well, partly it was the work that I'd done before on child sexual abuse and on why doctors and health visitors and psychiatrists, people working in the community, can't spot the signs and do more to help children when they're in distress. But partly it's also my career before becoming a historian. So I was quite a late arrival in terms of professional history making. I got my first job in the academy in the university in 2018. But prior to that, I worked in children's services for probably more than 20 years in lots of different roles, mostly supporting families, developing new services, trying to get more money for services for children and families in London boroughs. So I guess this project really brings all of those interests together, and I feel like it helps me to be able to speak to the different parties that are involved, to our partner agencies, to practitioners, and to people with lived experience. Yes, so I'm a historian, which basically means I have a PhD in history. I'm trained as an American historian, which this project focuses on Britain, Ireland, so England, Wales, Scotland, and all parts of Ireland, the island of Ireland. But there are a lot of, I guess, connections to America. A lot of ideas went back and forth across the Atlantic. So my training in American history is really relevant. I'm an oral historian and an archival historian. So I seek out people to talk to who may not find their way into the historical record. You know, they may not be rich or powerful or white or adults even. So, you know, at the times when their histories were written. So it's trying to find out more about their lives and also to help build an archive that expresses people's experiences and that is inclusive, diverse, all of those things that we care about. But my interests as a historian are in history of medicine and child welfare and very much in the histories of children and families. So these are all sort of areas that weren't considered like proper history until probably the late 20th century. And now we sort of venture into those private worlds and try and find out more about how ideas and experiences and emotions have changed over time. And I really look at the period of the second half of the 20th century up until today. So I have just published my first book, which I'm really excited about. It's got the very boring title of Community Health Practitioners and Child Sexual Abuse in the Family, 1970s to 2010s. Has to apparently do exactly what it says on the tin, or the Google searches and all of the AI bots won't find it on the internet. So that's why it has a very boring name. But it's basically looking at why there's a sort of surface acceptance within different health professions to the idea that they have a duty and a role to identify child sexual abuse in the family home and respond to it. But there's actually been very little progress made over the last sort of 50 to 70 years in achieving that and in helping children early who are in distress and who are being abused in the family home. And there's a kind of a myth that children don't tell, or it takes them like on average 2 decades to tell, and they're adults when they tell. It may be true that they aren't able to make anyone listen or notice their distress until they're adults. But more recent research with children, young people, or young adults shows very clearly that they do try and tell people, either using words or by their behaviors, and that there is a level of refusing to accept what is there and refusing to engage with children directly and refusing to ask them direct questions like, did somebody hurt you? Did something happen to you? Would you like to talk to me about it? So professionals fear getting involved. And I think that's such a wasted opportunity, particularly in professions that meet children day to day, you know, in the community. And those were the sorts of professions that I looked at that come into contact with children, young people, or non-abusing parents who are mostly mothers or the female caregivers. In most cases, the abuser is a male and someone known to the child, despite what you might think from the media. So it was really looking at that, but in a way that would not be critical of people and would not be blaming of people or policies, but try to really, through oral histories and through getting a really rich and deep picture of people's experiences across the professions, to try and really understand why progress is so slow and difficult. And I think by talking to practitioners and having that conversation that we can play back and discuss with them, it's very much more powerful than just looking at policies and what the government or what the professional organizations think should happen. This is looking at what actually happened and what could perhaps be different. It's a very emotional topic, lots of feelings are stirred up in people when you talk about sexual abuse and sexual violence. Many people don't want to talk about it. It's a conversation stopper at parties when people say, what do you do? But I don't think we should be cowed by that. I think we do have to speak out and speak up about it. But I think one of the most difficult things about it is that there are so many different ideas about language and about what it's acceptable to say or voice or name in society, that sometimes it can be a little bit paralyzing and people are afraid to speak up. And I hope our project kind of comes from a position of good faith and trying to learn about what people want and tries to treat people as individuals while not shying away from difficult conversations. But basically, I think looking after people's feelings, but still trying to take a critical look at what's happened in the past and what's happening now is part of our job. And bridging those two things is one of our hardest tasks, I think, in researching child sexual abuse or even sexual violence more broadly.